Well, firstly, welcome everybody. HRA is really pleased to be able to host today's event. This is the first in a series of 3 webinars. The webinars are really focused on trying to build consensus for our September roundtable, which is occurring in Canberra. And it's really with a view to informing the National Opioid Drug Treatment Program consensus statement. Our aim is to work with people who've got deep expertise, experience and skills in this area. And we're working with a range of different groups to try and build consensus around important and necessary reforms for the ODTP program. So it's a great pleasure to welcome you all. I'm coming to you from Gudabanud country in southwest Victoria. I want to pay my deepest respects to elders past, present and emerging. Today's a great opportunity to hear from a range of speakers who'll be providing a perspective around the evidence and priorities that are necessary for building that consensus towards that statement in September. For those of you who don't know me, apart from being a washed-up old senator, some of you might be wondering what the hell I'm doing chairing today's event. So I'm on the board of Harm Reduction Australia, and it's been a wonderful opportunity to work with a terrific organisation doing very important work. For those of you who don't know, I'm also a method prescriber and am back prescribing in regional Victoria. But before that, it's a sector I've worked in for a long time. So I spent a bit of time in Turning Point prior to my time in the Senate, working on opioid replacement therapy policy. I helped establish a method program in northeast India with the National Institute. I've also been working in recent years on a really important project that I hope has really just been temporarily delayed, and that's the second supervised injecting room for Victoria, which was to be built in Melbourne CBD but has been hopefully put on hold temporarily. So I come at this issue from a range of perspectives. I've experienced it as both as I say, clinician, a policymaker and public health specialist. And I don't need to tell any of you just how important it is that we continue to improve access to what is, we know, life-saving treatment for patients. We know that the area is racked with a range of cross-jurisdictional problems. We know that there are limited options available to clients in Australia. And we really want to build a world-class program so that we can ensure that everybody gets access to this very important treatment. So that's how I come at this. A little bit of housekeeping. There's an opportunity to ask questions of the speakers. Best to do that through the chat. So I'll be keeping an eye on the chat, and we're going to hear from people. And at the conclusion of their speeches, which we've sort of broken up into several parts, and I'll come to those in a moment, but just put your questions in the chat. If you've got any comments to make on what you've heard, put it in the chat. As I said, we'll be keeping an eye on that, and it's an opportunity to ensure that everybody is able to contribute to what's a very important piece of work. Please keep yourself on mute. As I said, the chat's the appropriate place for any questions. And with that, we do aim to, we will conclude certainly within the allocated time frame. But if the questions, we don't get as many as we expect, or our speakers run a little bit ahead of time, I've got to tell you, as a politician, that'll be a first for me. But if we run a bit ahead of time, we hope to give you back a little bit of time at the end of the day, but we will be finishing on time. So with that, let's hear from our first speaker. So I want to firstly introduce Annie Madden. Now, I've had the pleasure of working with Annie as a board member of Harm Reduction Australia, but also often would sit across a desk from Annie when I was in Parliament. And Annie's somebody who's got tremendous respect from right across the community. She's been doing wonderful work at Harm Reduction Australia. She's a part-time project lead at the International Network of People Who Use Drugs. She's a wonderful advocate, works across a range of areas, research, policy, practice. She's very practical, and she's one of the driving forces behind the work that we're doing here today. She's dedicated much of her life to improving the health, the human rights and the dignity of people who use drugs. So it's my great pleasure to welcome Annie as our first speaker.
Thank you, Richard. That's a very lovely introduction, and I appreciate it very much. So, Liz, I might get you to bring up the slides if you can, and we'll just click through to my first slide, which I think it's about slide 4. So everyone, just to start, I want to also acknowledge that I'm on the unceded lands of the Wurundjeri people, and would like to pay my respects to elders past and present. Liz, can you just go to the next slide, please? I'd also just like to give a reminder to put your questions and comments in the chat. We really do want to hear from you today. This is about presentations and information, but it is, as Richard said, also about consultation and building consensus, and all of us involved across all the wide range of organisations involved in this process are genuinely keen to make sure that everyone who feels they should have a voice in the process gets that opportunity as best as we can allow that. So please do that. We dearly would have loved to have allowed people just to put their hand up and ask questions and make comments, but we were very fortunate in having a lot of people register. We've got a growing group of people online, and that was just going to be a bit hard to manage. So if you can bear with us on that. So, and then lastly, I'm just letting you know, I'm going to be speaking from notes today, which I don't sort of do a lot, but I am talking today about a couple of specific documents. And so I really wanted to make sure that I've got a lot of detail to get through in a fairly short space of time, and I really wanted to make sure I got the information right for you. So with that said, my presentation today is going to focus on the PBS, or the first part of my presentation, should I say, is going to focus on the PBS post-market review report to PBAC, which is the Pharmaceutical Benefits Advisory Committee, from March 2023. Now, before I get into the report itself, however, I want to take you through a very brief history of the advocacy work that led to the PBAC post-market review on opioid dependence treatment, because that process and the report itself both represent very important background material, I think, for the current advocacy that we are doing in the OTP space at the moment. So let's get into it. So next slide, please, Liz. So actually, the origins of the post-market review are often misunderstood. So it wasn't established because of a routine PBAC review, which many PMRs can be from that. It emerged because across 2019 and early 2020, multiple letters were written to the then Federal Health Minister, Greg Hunt, about concerns with the private, uncapped and unregulated daily dispensing fees that the majority of OTP service users were being forced to pay. This issue had been raised for decades, but without success. But in 2019 and early 2020, letters were written, a budget submission was made with full costings, and the issue was also raised at Senate estimates and other parliamentary committees. That combined advocacy produced an effect, and in December 2020, the department commenced consultation on what they said was just an update to the legislative instrument for the Section 100 Opioid Dependence Treatment Program. So the department, I think, was hoping for this to be a very quick process of updating the program's legislative instrument. And these legislative instruments are actually required under the Health Act for this program and for others. But we realised that this, in fact, was an opportunity. The department was in effect attempting to codify a program that we felt was in desperate need of reform. So we made it clear that we weren't interested in a cursory consultation on the legal instrument, but rather we wanted a much broader conversation with government about problems with affordability, problems with access, and the way the program itself was operating. So recognising that these issues couldn't be resolved by legislative drafting alone, the then Minister announced a formal PBAC post-market review in March 2021. Over the following 18 months, the review became one of the most comprehensive examinations of Australia's opioid treatment system in decades, with consultations involving consumers, clinicians, pharmacists, jurisdictions, and peak bodies, a full literature review, stakeholder and consumer workshops, and a public call for submissions. And importantly, the review even continued seamlessly, really, following the change of government in May 2022, when Mark Butler became the Federal Health Minister. Change slide, please. By October 2022, there was an additional imperative. Amendments to the National Health Act meant that all Section 100 programs now needed to have a new legislative instrument by 1 July 2023. And if you remember what I've just said, the S100 ODTP program didn't have a current registered legislative instrument in place because that was the trigger for the PMR review in the first place. So as you can imagine, this triggered an urgent timeline, which was made even tighter because rather than wait for the full review, Minister Butler in late 2022 requested an interim advice from PBAC so government could make decisions in time about the future of the program before the 1 July 2023 legislative deadline. The interim report from PBAC was delivered in March 2023, and although it was a pretty touch and go in the 11th hour whether the reforms would actually be implemented, in the end, the interim report became what I would call a blueprint for reform. Key recommendations including improving affordability, simplifying PBS arrangements, and moving medicines into the highly specialised drugs community access program was subsequently adopted by government and funded through the 2023 May federal budget and commenced on 1 July 2023. It's worth noting here that this was the single biggest federal government investment in the opioid treatment program possibly ever, but certainly in decades, with over something like $377 million over 4 years, plus ongoing funding to support the reforms. It was, by all accounts, a major win for all the advocacy that had gone before. And of course, the story doesn't end there. Since 1 July 2023, the focus has shifted from policy design into implementation, and it has been supported by an expert advisory group that has been given the job of sort of troubleshooting and addressing sort of operational issues as the reforms have been rolled out. Next slide, please. Although these reforms were rushed, leading to some implementation problems, it's important to acknowledge just how significant the July 2023 reforms were. Affordability had emerged very clearly through the review as the #1 immediate priority. For the first time, people accessing opioid treatment medicines through community pharmacy, which is the majority of people, by the way, on opioid treatment, were brought properly within the PBS co-payment and safety net arrangements, and the system of unregulated, uncapped and discriminatory dosing fees was fundamentally changed. The majority of service users, for example, went from paying a minimum of $7 a day to paying around $7 a month. And again, I mean, that is really just incredible. But I think this is where we need to distinguish between reforming the way medicines are funded and paid for and reforming opioid treatment itself. The PMR was actually much broader than a financing review. It examined models of care, consumer experience, treatment choice, workforce, takeaways, jurisdictional inconsistency, rural and remote access, First Nations access, continuity of care, stigma and discrimination, and the national guidelines. And the principles it arrived at, if done properly, could make for a very different and much better experience of opioid treatment, because at the very least, the PMR report says future opioid treatment should be based on person-centered care, autonomy and shared decision-making, equitable access, safety, inclusivity, destigmatization, and choice. So my proposition is simple. In 2023, we fixed an enormously important part of the problem, but we did not finish the work identified by the PMR. And it's that unfinished business that I want to turn to now. Next slide, please. The first major piece of unfinished business is national coherence. The Commonwealth funds the medicines, but the states and territories continue to determine many of the things that shape a person's actual experience of treatment. Who can prescribe, accreditation requirements, supervised dosing, takeaways, dosing sites, transfers, and other program rules. The PMR found very substantial variation between jurisdictions and explicitly said that holistic reform would require Commonwealth and the states and territories to work together. Indeed, in section 6.3.1, it identifies greater access to flexible unsupervised dosing, more consistent rules between jurisdictions while improving autonomy, less restrictive prescriber accreditation, ongoing public treatment options, better continuity between custody, hospital, and community, culturally safe access through ARCHOs, and improved national data. And critically, the PMR called for the 2014 national guidelines to be updated. Those guidelines not only predated LAIB, but also predated many of the important service innovations we saw during COVID, including greater flexibility with takeaways that we are now seeing being rolled back in many jurisdictions. So affordability may now be nationally consistent, but the experience of treatment is still heavily determined by postcode. Next slide, please. The second piece of unfinished business is access. And this is where we need to resist equating affordability with access. The PMR found that roughly 10% of prescribers were responsible for 80% of OTP prescribing. It also identified an aging OTP workforce and difficulties recruiting and retaining GPs. The report is quite explicit that prescriber shortages, particularly in regional and remote Australia, reduce access and contribute to waiting lists, financial burden, and stigma. It proposes telehealth, case management support, undergraduate and postgraduate training, greater involvement of nurse practitioners, and consideration of funding or incentive mechanisms. And there is another important finding. The review says explicitly that this treatment cannot be provided exclusively through private GP/community pharmacy sector. It says ongoing state and territory public treatment options remain necessary, particularly for people with more complex needs. The PMR also recognises continuity of treatment as an access issue, particularly when people leave prison, move into state, or transfer between hospital and community care. So the next stage of reform has to ask not simply, can someone afford their medicine, but can they actually find a prescriber, access an appropriate service, choose a model that works for them, and remain in treatment even when their circumstances change. Next slide. For me, this is perhaps the most important unfinished business. The review didn't only consult governments, clinicians, and pharmacists. There was a dedicated community consultation coordinated by AVIL involving 106 people participating in opioid treatment programs across Australia. And what people described was striking. Treatment had enabled many people to stabilise their lives, work, and study. But accessing it was frequently experienced as difficult, restrictive, and complicated. The broader evidence review came to much the same conclusion. Facilitators to treatment included autonomy, shared decision-making, flexibility, non-judgmental treatment, and holistic support. Barriers to treatment included stigma, restrictive opening hours, lack of privacy, time-consuming supervised dosing, and rigid takeaway arrangements. Choice also comes through repeatedly. Not just choice between methadone and buprenorphine, but choice of medication, of formulation, dose, provider, dosing arrangements, and treatment setting. That's particularly important with LAIB. The review recognised its considerable benefits for some people, while also documenting concerns about loss of control and erosion of choice for others. The report is clear that different medicines suit different people and treatment choice should reflect individual needs. None of those questions were resolved simply by changing the PBS payment mechanism. A modern opioid treatment system, therefore, cannot just be clinically effective and financially accessible, it also has to be ethical, non-punitive, flexible, and genuinely meet people's needs. Next slide, please. And this brings me to why I think the unfinished business of the PMR represents such an important advocacy opportunity for us all. We're not starting from scratch. We're not asking government to accept these problems exist for the first time. They're not hearing these things for the first time. Indeed, this is a Department of Health and Aged Care review. It was prepared for the Pharmaceutical Benefits Advisory Committee. It was informed by research, state and territory governments, prescribers, pharmacists, service providers, community organisations, and importantly, people receiving treatment. And in its final section, it doesn't stop with affordability. It explicitly identifies broader matters on which PBAC could advise government: state and territory policy, national guidelines, the prescriber workforce, access to LAIB administration, and First Nations access, to name just a few. The 2023 reforms dealt with the urgent PBS component of that agenda, and they were a major achievement in themselves, as I've said. But the broader reform agenda has not been taken forward through an equivalent national process. Indeed, the government's current PMR webpage still essentially concludes the policy story with the March 2023 PBAC decision and the 2023-24 budget reforms. So I think there is a legitimate question for us to ask. What happened to the rest of the review? And that's where the Canberra Forum comes in, I guess. We have an unusual opportunity here to bring together the evidence and the unfinished agenda from the PMR with a contemporary sector-wide reform agenda. The PMR tells us a great deal about what's wrong and what needs further attention. The HRA policy brief, which I'm going to turn now, asks the next question in that picture, which is, what should Australia do about these unresolved issues? But before I turn to that, I want to stop for a few minutes here, give a chance for any questions or comments about the PMR report, or any comments about what you think about the unfinished business that I have identified from that report. And for that, I'll hand back to Richard, and then I'll come back and talk about HRA's policy and what we should do. Thanks, Richard.
Thanks very much, Annie. That's terrific. Look, just a reminder, use the chat if you've got any questions. Again, a bit more housekeeping. We are going to be making a recording of the webinar available along with the transcript. We might have missed the first bit of the transcript. I do see that you might have already answered a question from Alison Ritter. Wonderful to see you again, Alice, or at least hear from you again, Alison. Alison was just, I think, wanted to know whether the post-market review recommended specifically that new national guidelines be developed, which I know you were addressing your topic. I just know, is there anything further you wanted to add to that, Annie, before you
Yeah,
move to the
I think
second
it's a
part of your
little more
presentation?
nuanced than recommending new national guidelines be developed. But certainly there are recommendations in there around the guidelines needing to be updated and being out of date. So where then that goes, and yeah, this is a tricky question because we know that so far we've felt from government that there isn't a great deal of appetite necessarily for updating those guidelines. But of course, many of us agree that there is a really important role for national guidelines to play in a space like this, particularly when if you couple that with the other issue identified in the review, which is inconsistencies between jurisdictions, that is an opportunity, if you like, for a new set of national guidelines updated in a contemporary way, bringing on board things like LAIB, which, as I said, the guidelines were developed, the current guidelines were developed before that was available, but bringing all of that together to really sort of have a nationally consistent way forward on the opioid treatment program. It makes sense. And I think we have national guidelines, as I understand it, for many other areas of chronic disease and other issues that are seen as nationally important health issues. And I can't really understand why we wouldn't want to have an updated set of guidelines on this. I hope that answers that.
That's great, Annie. And I can perhaps I can just add to that as a prescriber who's just gone back to prescribing, I feel like I've stepped back in time. I left off 15, almost 20 years ago now, and there's been very little change. In fact, the fragmentation, the cross-jurisdictional issues, they remain unaddressed. We've got a few developments and innovations, but they're few and far between, and much of the old architecture remains, making it difficult for clients and difficult for prescribers. I can't see. Oh no, we've just had a question from Anne-Marie Jones, who's wondering about any unforeseen consequences of the changes. So loss of community pharmacy dosing points, private clinics. That have had a major impact on service delivery, and particularly in rural and remote areas.
Yeah. Okay. So I'm not going to pretend that, there weren't unforeseen consequences. Of course, there have been, and there were responses to that, I think, so that was what I was getting at in my presentation around flagging the very fast time frame that ended up kind of putting pressure on this process and things having to move very quickly to meet that 1 July 2023 legislative deadline. And that meant that things did have to move, I think, unfortunately, faster than many would have liked. What would have been ideal, I think, for such a major change to the system. And I think also, it wasn't probably also communicated very well, the changes from the Commonwealth level, and that also created unnecessary concerns, I think. But I do need to say that I think in terms of, I'll take the private clinics first, and I'm very happy to stand on record about this, but I think, they were some of the places where these unregulated, uncapped fees were really, really high and reaching really ridiculous levels. And I think, that my understanding is people who were being dosed at private clinics, states and territories work very hard to find people placement in GP, community pharmacy programs, and other settings that meet their needs. And some of those private clinics actually transitioned to become a different setup altogether and do the sort of GP community pharmacy arrangement. So I think, over time, those kinds of teething issues, if you like, had sorted out. I think, there's a lot of conflicting information about the impact that these changes have had on community pharmacy. Some pharmacists say, well, look, this funding structure is different and we now need to kind of report and record and get reimbursed for these drugs in the same way as we do with many other, any other PBS medication. It was just a matter of having to kind of time to sort of change systems and get everything in place. But it's, relatively the same. But others have been very disgruntled about those changes and have used it as a reason to leave the space. I'm not a pharmacist. I don't know the ins and outs. And as far as I know, there is no actual real information or data around this issue. And I think that would be something that would be worth investigating further. Very happy to hear from anyone online who does know more about that in the chat. Yeah.
Thanks, Annie. Annie, we've had a follow-up from Alison. I think there are a couple of other questions which are probably best suited to the second part of your presentation. So Alison's asking whether the Commonwealth or the PMR report authors, what did they think would happen with the recommendations which haven't been implemented? So is there any intention to reactivate those recommendations?
As I said I think this is a really important issue to raise, because I think, from a government perspective, there might be that temptation to say, well, we're the federal government, we've done our piece of the picture, and now most of these issues are jurisdictional issues, and that's where they sit and need to be taken up there. But I think it's very important to highlight that the PMR report, in fact, did highlight that there was quite a few issues that the government, the federal government, could continue working on through PBAC or through other mechanisms. So I think there is direction in the report for sure that there was an intention from the writers that the work wouldn't just be on the financing, and that the other parts of the review would actually progress, and that this first report was really an interim report that was required by the minister at the time for the legislative deadline, but that there were a lot of other issues that needed attention. And the way the report reads to me is that there was full intention that this process should continue. Yeah.
That's great. Thank you, Annie. Look, we'll just I think we should move on to the second part of your presentation, Annie, which really is about, I think, perhaps a way forward. It speaks to the recently released Harm Reduction Australia policy brief. I think, Annie, you're going to talk to how it was developed and how it responds specifically to some of the unfinished business from the post-market review report.
Yeah, right. I'm just going to get rid of the chat here. Yeah, right. Thank you. Thanks, Liz. Okay, so next slide, please. Great. So as Richard said, I'm going to now talk a little bit about HRA's Reforming Australia's Opioid Treatment Program policy brief that you can see over there on my slides. So basically, here we are in 2025, and that's the point at which really I think the next phase of all this OTP advocacy story commences, certainly from HRA's perspective anyway. So next slide, please. By mid-2025, we at HRA definitely were getting increasingly frustrated. The July 2023 reforms had addressed an enormously important issue, but there was very little indication that governments intended to progress the broader reform agenda through the PMR that was identified through the PMR. Across the first half of 2025, we had sought meetings, we'd written to the minister multiple times, we'd raised the issues publicly and through the media, and we'd had continued conversations with senior Commonwealth officials. But it became increasingly clear to us that there was no obvious appetite for a second phase of reform. For HRA, that was concerning because, as we've just seen, the PMR had already provided a remarkable and very strong blueprint for reform. So we decided the issue didn't need another diagnostic exercise on top of the PMR. What it needed was renewed political attention and a clear advocacy agenda. Next slide, please. One of our early decisions was that we were not going to undertake another large-scale consultation process, and that was very deliberate. The PMR had already undertaken one of the most extensive consultation exercises in the history of Australian opioid treatment program. It included 35 formal submissions through the public submission process, many of them that were very extensive, a national stakeholder forum, a targeted consultation with people receiving treatment. So we didn't think it was either necessary or, in fact, respectful to go back to people and ask them to tell us the same things all over again. Instead, we used the PMR as a foundational evidence source and tested and developed its continuing relevance through the HRA board and its membership, and through in-depth discussions with people who understand the system from different perspectives. So consumer advocates, GPs, nurse practitioners, AOD specialists, pharmacists, and others. Our job was not to rediscover the problems. It was to decide which reforms should now be prioritised, how they should be expressed, and how we could turn the evidence into an advocacy tool. Next slide, please. We were also very clear about what we didn't want. We didn't want another 80-page report that people congratulate us on, download once, and then never open again. You know, the report that sits on the, electronic shelf, as it were. We wanted a genuine policy brief, concise, accessible, and usable. Externally, it needed to make sense to policymakers and people who are not opioid treatment specialists. Internally, it needed to serve another very practical purpose. We wanted every HRA board member, staff member, and advocate to have a high-quality document that they could turn to whenever we were asked, what does HRA think needs to happen in the opioid treatment space? In other words, we wanted all of us singing from the same song sheet, as they say. That internal discipline has actually been one of the most useful outcomes of the brief. Rather than having 20 slightly different versions of what reform means, we now have 6 clear priorities around which our advocacy can consistently organise. The brief itself was designed as a compact 7-page document, beginning with the 6 recommendations on page 1, rather than burying them at the end. Next slide, please. For anyone who hasn't read the brief, the structure is intentionally straightforward. We start with the problem, which is despite Australia having a long-established program, major barriers remain. Too few services, long travel distances and waiting lists, rural inequity, a fragile workforce, and significant variation between states and territories. We then move into the policy context and the evidence. The PMR is, of course, central in that evidence, but we also drew on NOPSAD data, the workforce research, the evidence on mortality and retention, lessons from COVID-era reforms, international experience, and HRA's own work on stigma and discrimination. Importantly, the brief goes further than the PMR in some areas. For example, explicitly challenging control and surveillance-based practices, raising the need for a wider range of medicines and formulations, and placing rights-based care much more strongly at the centre of reform. And then we get quickly to the point. 6 areas where HRA believes action is now required. Change slide, please. This section was really important to us strategically. It isn't enough in advocacy to tell government that something is unfair or that the sector wants change. We also have to answer the policy question. What do I get if I do this? So we deliberately included a section called 5 Ways Our Recommendations Deliver Public and Policy Wins. The point is that these reforms don't benefit some narrow interest group at the expense of the system. They produce outcomes governments already say they want. Better health outcomes, improved treatment engagement, better rural access, greater national consistency, less red tape, and a more sustainable health workforce. And this is important politically. Person-centred and rights-based reform does not mean abandoning safety, effectiveness, or accountability. In many cases, it means achieving those objectives better by designing treatment around people's real lives rather than expecting people to organise their lives around a treatment system. So one of our advocacy messages is this is both the right thing to do and sensible public policy. Next page. These are the 6 recommendations around which the entire brief is organised. The first 3 are strongly about capacity and access. Expand the workforce, increase pharmacy participation, and improve access in underserved communities. The 4th is about modernising the actual treatment model. More rational takeaway policies, less unnecessary regulation, better national consistency, greater treatment choice, and individualised care. The 5th is deliberately more values-based. Embed person-centred and rights-based principles. This means living experience in design, tackling stigma directly, and reviewing laws and policies that prevent person-centred and rights-based care. And the 6th asks for the national architecture needed to sustain all of the above to be updated via guidelines, a national advisory mechanism, and long-term funding and proper evaluation. These aren't 6 unrelated asks or priorities. Together, they describe what we think a modern national opioid treatment system should look like. Next. And I guess, that sort of brings the 2 parts of today's presentation together, really. The HRA policy brief is not an alternative to the PMR report. In many respects, it's an attempt to carry forward its unfinished reform agenda and turn it into a sharper advocacy platform. The workforce recommendation maps directly onto the PMR's concerns about prescriber sustainability. Our access recommendations respond to the geographic and service gaps the PMR identifies. Our call for harmonisation reflects its findings about jurisdictional inconsistencies. And our emphasis on autonomy, choice, and flexible treatment is entirely consistent with the PMR's own essential principles of person-centred care and shared decision-making. Where HRA pushes further is in making those principles more explicitly rights-based, in challenging punitive practices, and in asking what the program should look like for the next decade, rather than simply repairing the current structure. Our brief was launched on 2nd of December 2025. And so now, I guess, we're trying to take the next step in that process. These 6 recommendations have helped underpin the draft National ODTP consensus statement that we are currently developing ahead of the Canberra Roundtable that will be held at Parliament House on 7 September. We don't want to arrive in Canberra with a finished statement that simply asks people to endorse it. This webinar, and indeed the 2 to follow, are part of that consensus building process. So as we move into some further discussion today, we really want to hear from you. So I want to finish by thanking you, first of all, for your attention on my 2 presentations today. But I also want to leave you with some questions that we would love to hear from you on, whether it's today in the chat or whether it's over the next few weeks. You can reach out to any of the organisations involved. But they are: do these 6 HRA priorities capture where reform needs to go from your perspective? Is there anything missing? And importantly, is there anything in the HRA priorities that might need to be strengthened, changed, or framed differently? So I'll leave you with those kinds of questions. They are genuine questions. We genuinely want to hear from you. So with that, I guess I'll hand back to Richard and maybe for some more questions, or otherwise moving on to our next presenters. Thanks for your time.
Thanks very much, Annie. That was terrific. I've got a couple more questions. You addressed the issue of workforce in the HRA policy brief, and this one specifically goes to the potential to expand the scope of nurse practitioners and indeed registered nurse prescribing as a key part of enhancing access, particularly in rural and regional communities where there are huge shortages of prescribers. So is there anything more that you might want to add to that to that specific issue?
Yeah, look, completely agree that that is a really critical space to develop. We've seen several jurisdictions really running with that issue and looking at ways to expand the number of nurse practitioners in the OTP space in their jurisdictions. And from a consumer perspective, we hear really great things from consumers about working with nurse practitioners in terms of their treatment. So I think it's a really great option. In fact, personally, I have recently moved to a nurse practitioner for my OTP prescribing, so I can attest to that on a personal level that it's really great, and I'm really enjoying having a nurse practitioner doing my prescribing and other health matters that they can manage. So yes, I think it's a really great part of the picture is what I guess I'd say to you. None of these things are solutions of themselves, but there's lots of things that are going to need to be done to make up that workforce picture, and that is definitely one of them. I just think that there are still quite a few things that we need to talk with nurse practitioners about, quite frankly, around remuneration and making sure that the regulatory and guidelines and policy frameworks are all kind of in place to support them coming into the space. Because it's one thing to say we want more nurse practitioners, but it's quite another to attract them into the space with a system that is genuinely set up to support them and make sure that they can do their job and work effectively. So I would just probably end by saying that, and just saying, look, this is a policy brief as well. As I said, we wanted to keep it intentionally brief and short. So there will be things that we mention but don't elaborate on, but that shouldn't be taken to mean that we don't have, further views on what needs to be done in that space. Thanks.
Great. Another question. This is from Jared McMore, who's from the Pharmaceutical Society of Australia, who was involved in helping advise the department around the funding for pharmacy. So if I'm to summarise, and I think it's pretty self-explanatory from Jared's comments in the chat, but while I think there's an understanding that this has been an improvement for people who are accessing the system, in terms of pharmacists, a few issues have come up, more paperwork, minor issue, some of it solved, but I've got to tell you again, as a prescriber, drives me nuts as well. I think there's an issue with cash flow. It's a bit slower, but I suppose the main issue is that when the funding for pharmacists was sort of benchmarked against existing practices, the challenge was it was starting off a very low base, because even though some pharmacists were charging significant fees, others were probably subsidising the provision of this service, and the result is we've started from a low base and there's no indexation.
Right.
So I suppose the question is, how do we address that issue to ensure that the cost of delivering the service increases over time, at least with inflation, if nothing else?
Well, look, this is kind of an area that I think Jared would be far better placed than me to answer the question he's raised or you've raised, Richard. I haven't seen the chat, so I'm not sure where that comes from. But I think that just, with my limited knowledge, I guess I would just say again that in many ways the PMR interim report, which is what it was that all the funding arrangements were based on, and the reforms, really still represents a very good opportunity to go back to talk about some of these unintended consequences, some of this unfinished business. I mean, this also can be part of the advocacy agenda, if you like. Just because there were those reforms in July 2023 and as they rolled out across 2024 doesn't mean to say that that's the last time we ever look at that issue. So I think, my advice would be that we should actually do the work to put together a convincing argument to government about what else might be needed. They've made these reforms, they've made this step, they've obviously made a massive investment. So, my gut would tell me they'd probably be willing to entertain the thought of getting it, ticking off all the final pieces that need to be in place. But, I think it's an advocacy piece, really, building on what's already happened.
Thanks, Annie. And I think relating to that, there was also a comment around the remuneration for long-acting injectable buprenorphine, which isn't really the same thing as providing someone with a vaccine yet attracts the same level of remuneration. Right. And I suspect your answer will be the same there, that it's just a function of ensuring that we present those arguments and continue to advocate. And just finally on that, earlier there was a question around how do we actually who do we put the pressure on it? Does pressure on the Federal Department of Health and Aged Care, does that work? Will that facilitate the federal government taking some responsibility for it? I mean, I could probably say a couple of things on that.
Yeah, go for it. I think you're far better placed than me in many ways.
Well, yes. I mean, I was spectacularly unsuccessful in most of my advocacy, so I suppose I would take it all with a grain of salt. But I think you've got to keep pushing across all parts of the system. Again, it is an indictment that, and it really is a function of the stigma that exists around this topic, that we don't have national guidelines and a national approach. I think direct pressure on the federal government and advocacy from all of the various stakeholders that work in this area is critical. Pressure on the federal department, although it's a bit chicken and egg, mostly. The department will act according to the priorities and wishes of the government of the day. So I suppose I think the minister has shown himself to be open to these conversations, and I think it's really important that he continues to hear from us. And that's really the function of what we're trying to do today, is to ensure that we've got the collective voices of the technical experts, the people with lived experience, public policy experts, clinicians, prescribers, just people working across the sector. So I suppose my answer to that would be exert it wherever you can, because it's often, we don't know where when you're pushing, you might be pushing on an open door and you don't realise it. So it's very important to just keep exerting as much pressure across the system as you can. Annie, is there anything else you wanted to say in closing off?
No, really, I guess, no, I'm going no, but yes, what I will actually just say is just to reiterate that, we do want to hear from people. The thing with the Canberra Forum is we've got a limited venue and there's only about 80 people can fit in the room. So we've got a much larger sector than that. Not everyone's going to be able to attend that forum. It is invitation only, but that isn't the be all and end all. We really want to make the most of these next kind of few weeks leading into the 7th of September, the webinars to come. And just any opportunity you have, if you want to express views, if there are issues that aren't being raised sufficiently in your view, or there's gaps or things we're underestimating, by all means, please reach out. We'll ensure that those of us in various organisations will come back to this at the end, but we'll make sure that your comments do get through. And as Richard said, that's really critical for building consensus, where we're all kind of saying, government's getting consistent messages from the sector, because that divide and conquer can really work against us when it seems like we've got division within the sector. So I think let's work together to get some really strong messages for future reform and see what we can make happen. Thank you very much.
Thanks, Annie, for a wonderful presentation. I've got the pleasure of introducing our next speakers. So we're going to hear from Anna McVinish and Dr. Jake Rance. Anna McVinish was the nurse clinical lead for Australia's first study looking at the feasibility of supervised injectable opioid treatment. She also was awarded a Churchill Fellowship to look at heroin-assisted treatment models internationally. She currently works for New South Wales Health as a clinical nurse consultant in community liaison, and he's a clinical advisor to HRA. Jake's worked in the harm reduction field and drugs field for nearly 30 years as a practitioner and researcher. After a decade in King's Cross, he then joined the Centre for Social Research in Health at UNSW in Sydney. And most recently, he also worked on Australia's feasibility trial of supervised injectable opioid treatment. And those of us in Victoria, where a small trial is hopefully going to begin, we really look forward to hearing from you about your experience. So we're going to hear from both of them around the practical examples and lessons that they've learned from other countries. And then again, we'll have the opportunity for questions and discussion through the chat. So over to Anna and Jake.
Thank you very much, Richard. Thank you, Annie. Anna and I are coming to you today, joining you from the beautiful unceded lands of the Gadigal people. Always will be Aboriginal land. So I'd like to start with a little bit of background. From 2022, I worked for several years on what became known as FOPIT, the feasibility of injectable opioid treatment. FOPIT was the first trial of supervised injectable opioid treatment since the Howard government vetoed the ACT heroin trial back in 1997. In a nutshell, the people participating in FOPIT were offered twice daily injectable hydromorphone for up to 2 years in conjunction with standard opioid dependence treatment, typically methadone, but also bupe in a couple of occasions. After that 2-year period, they were offered ongoing maintenance on standard oral treatment. While FOPIT participants had their own small purpose-built injecting room located within an existing ODT service, they received their methadone or their bupe alongside everyone else at the clinic. It's important to know that this was not an efficacy trial. It wasn't an RCT. It was a feasibility trial. So the primary aims of the trial were to assess its feasibility and acceptability of this particular model of care, i.e. a time-limited, integrated, supervised injectable opioid treatment using hydromorphone. During the trial, it was not a trial, it was a pleasure to work with Anna, who was the original nurse unit manager at FOPIT. Anna and I have been having these conversations now, to anyone listening in ad nauseum probably for about 3 or 4 years. But more importantly, Anna went on to be awarded a Churchill Fellowship, which funded her to undertake a whirlwind tour of injectable treatment programs across both Europe and Canada. In the lead up to the Canberra Roundtable, Anna and I think that a critical part of our work requires imagining how opioid dependence treatment in Australia could be done differently. With this in mind, I'll hand over to Anna. Thanks, Anna.
Thanks, Jake. Thank you. I feel immensely privileged to be amongst such illustrious colleagues and, as Jake acknowledged, on the unceded lands of the Gadigal. May we go to the next slide, please, Liz or Jay? So in the context, and we've designed this in a kind of fireside chat, in the spirit of a fireside chat without the fireside, but in the process of our kind of coming to meet and understand the work that we were participants in also, as well as observing, I became very preoccupied with the absence of consensus guidelines around how this treatment was mobilised. Less of a focus on the molecule itself, I suppose, insofar as that we had the high concentration parenteral hydromorphone versus dimorphine as heroin-assisted treatment programs distribute by necessity elsewhere in the world. But what was initially, I mean, certainly a very captivating preoccupation, I found was not a very straightforward process. It was incredibly complex to differentiate treatment from the cultural setting, from the environmental setting, from who was delivering it, the types of objectives behind different treatment programs as I encountered them were hugely varied, and there were so many regulatory and other pressures at play that were very, very challenging to make any direct comparison between. And so ultimately, what I observed was that there were many differences, but they were not contradictions, rather they were dualities. And may we go to the next slide again, Liz, please? And to speak very briefly to this in this setting, there is so much we could cover, given we have a 4-year backlog of conversations. We'll share it another time, but very, very briefly for today, the first place that these photos that you see in front of you are from the time that I spent in Switzerland. Actually, I lied. The tablets that you can see on the lower right side of the screen are from Germany. These are methadone tablets. But it was important to mention that there was very limited uptake in syrup-based methadone. Most people opted for tablets. There's not a clinical rationale that I understand for delivering methadone, well, providing methadone in syrup form only, and that there was this kind of alternative formulation that I think gave people a more dignified experience, in fact, given my understanding is that the syrup formulation has been engineered to limit the risk of diversion. You can also see here in the pictures of the clinic space, this clinic in particular was designed with an absence of visual barriers in mind. It was long lines, it was very open. There's some small sections of frosted glass you can see. There's a small screen on the left side, but there was not the more restrictive approach that we might commonly encounter in this kind of, or expect to see in that kind of setting of receiving one's medication through a hole in bulletproof glass, for example, I could also, somewhat comically, make another whole project of like photos of drugs under open windows from this tour, because of how not unsafe, but how reasonable. There wasn't an inbuilt mistrust in the way that these treatments were delivered. That was new for me. You can also see on the right-hand side the combination of takeaway formulations available to this individual person, that they had injectable diamorphine, injectable heroin for takeaway doses prepared, ready for their collection, yet they also had some tablets. There's a number of reasons why that might be most useful for the person whose medication that is. Maybe there's a couple of mornings where they have to rush for the bus and they don't have time for venous access. All of those kinds of combinations of co-therapy choice were inbuilt and anticipated, not by every clinic, but certainly by the ones noted here.
And you were saying, Anna, that one of the reasons you think the Swiss afford so much variability across what is really quite a small country and a small population is partly down to experience, that they've been delivering heroin-assisted treatment since, 1996, I think?
Yeah.
And there's about 1,800 people who are currently on heroin-assisted treatment. And you were saying, I guess, what a profound difference that experience had meant.
Absolutely. May we go to the next slide again, please, Liz? Only just because this is another example, that what I saw in essence was the distillation and a very slow accumulation of what I think can only be called mastery, that over time and over the course of trial and error and a lot of mistakes, no doubt, and this was emphasized to me by the people that I met, that it wasn't that this was only a very straightforward or kind of sensical process always, that they had refined, they had taken opportunities to adjust, to resource differently, to refine the program according to what people were going to find most effective, according to what people asked for, according to what their ultimate goals were. And thus that work of refining over time, and the privilege of that time and the privilege of making mistakes as the first, where this is actually a really rich and important opportunity that we have to review the acquired wisdom of people delivering this treatment, because it became increasingly less focused on the molecule and more focused on the qualities of the program, seeking to retain people in treatment that meets their needs well. High quality treatment that meets people's needs is the goal. instead of concern around kind of regulatory kind of processes, or not that they weren't present, but they became less emphasized over time.
I mean, I guess what we know, and certainly what we saw through FOPIT, is that the relationship between treatment sought and treatment delivered is actually complex and nuanced, and how people will experience whatever, as you nicely put it, the molecule, whether it's diamorphine, heroin, whatever, their experience of the treatment can't be separated from the setting in which the treatment is provided and the way in which it's delivered, i.e. their relationship with clinicians.
Well, this also, and a very interesting, and again, huge variation. To go back to the original point of like accumulating all of these experiences, seeing these different sites and meeting different people, it became more and more complex to know how to write it down, insofar as this is a multiplicity of parts. And in fact, the most useful piece out of that spread was to recognize that injectable treatment, as we know, although it's some kind of pinnacle in Australia, some kind of capstone aimed for, as kind of how that we could push towards, extend ourselves towards. In fact, it's just another mark on a spectrum. And there are treatments beyond injectable treatment, and that all of these different approaches sit along that expanse of possibilities to meet individual patient cohorts' needs best. And again, in that setting of multiplicities, it demands that we focus on the principles at play, which are providing options that are going to work for people best, rather than becoming preoccupied with the kind of structural modality in a particular way. So on that, I was going to say, may we go to the next slide? Oh, sorry, I should explain these, before we do. This was a diamorphine takeaways just next to the kettle. I love this photo. It's super casual. People hadn't collected them yet. And this is also somebody with their injectable takeaways, just on the bench at the dispensary. Somebody had returned some, actually, I don't know that they returned the empty syringes, in fact, but they'd returned the box and it was refilled for them. This is regular clinical practice. May we go on to the next slide, please?
And Anna, can I just quickly throw in, I've got a few of my favourite quotes from FOPIT, and acknowledging that FOPIT was a trial and a very particular model of care. And I was fortunate enough to interview participants on the trial at 3 time points, including beginning, middle, and end. And what came through consistently was from participants was the importance of relationships that they developed with staff. And as we all do, that was more often than not a comparative exercise. These people were people who'd spent long periods of time on methadone, less commonly on buprenorphine, which for various reasons hadn't been helpful for them. Anyway, I love this quote. Because we're not getting I'd asked this person what was one of the distinctive things about their time on FOPIT, and this is what they said. Because we're not getting treated like children, people are trusted and treated like adults. Staff are actually asking your opinion and they're respecting your answer. When you already feel like no one's listening to you, that makes a huge difference. It was the first time that we felt like we were being seen. It felt like we were coming back every day to get support and using in a safe place. To have any opportunity where we can have a treatment, self-administered, something that we obviously really like, it works. We're already doing opiates and injecting opiates. So if it was any other way, it wouldn't have worked. Anyway, thanks, Anna. I thought I'd just throw that.
So this slide is perfectly timed with that quote, in fact. So while they're no longer afraid of the molecule, so to speak, in the Swiss setting. And I neglected to mention in the previous slides, in fact, there was the option, like flexibility is possible is the takeaway message. There was one particular site that had developed a software where people's prescription was by OMED, so oral morphine equivalent daily dose, and they could choose the formulation that suited them. I mean, as long as the individual medicines were compatible, but one might be able to choose to come into the clinic for injectable treatment in the afternoon. But if you had to go and meet with your child's teacher in the morning, maybe you wanted a slow release oral morphine tablet, in order that you didn't have the kind of, you didn't have to, anyhow, it would satisfy your needs differently in different settings. And so they had pushed through this kind of concern, I suppose, and regulatory anxiety around the medicine. And yet I wanted to include this slide because it cannot be separated from the treatment setting. And there was a very marked relationship between psychiatric treatment and opioid dependence treatment in the Swiss model and in the German model. And so there was this particular focus, and I raised it, I mean, partly it's a little bit tongue-in-cheek, but this was on site at a clinic where they had on display the woodwork that the kind of that program participants and different programs had made during their time that they had been receiving treatment there.
It's a lovely visual metaphor for longevity and mastery over time.
Well, indeed. And I thought this was appropriate at once to reflect, I mean, it's very Swiss. It's also very much the treatment provider's experience. But I think it also demonstrates, I think, that what they were providing in essence was a treatment for social exclusion in many respects, and that, again, in ensuring that treatment is landing best with the cohort who is asking for it, and what specifically those people are asking for includes making space for treatment programming that accounts for those social inclusion factors, for relational care, for mobilizing, like re-inviting people back in the absence of procurement stress, kind of to become reacquainted with the lives that they may have otherwise stayed, in the context of actually so many competing demands. And so I think there's a very strong theme across, I mean, and many of the clinic sites I had the privilege to visit, but they were not all consistent. And I think it's important to notice that actually there is choice in how and what is emphasized to whom in terms of landing this best, because again, the overriding principle is landing it best to retain people in highly effective, high quality treatment.
So can I throw in another quote from Foppet?
Please.
And this, once again, is about relationships between participants and staff. And it's self-evident. I don't need to explain to any of you. We can just imagine what the feeling of incredible relief, that respite from the constant hassle to get $800 a year together on a daily basis, the incredible sense of possibility that opens up when you're provided with a treatment, which actually means you're not going looking. And that's what people constantly reiterated in Foppet, that for various reasons, hydromorphone helped people in ways that historically they had found methadone or buprenorphine to be ineffective. As one person, and obviously methadone, this is not a critique of methadone. Methadone works and works really well for a lot of people. For these folk, it hadn't. And I remember one person saying, look, I would go and get my methadone, I'd pick it up, and as I walked down the ramp from the clinic, I'd be thinking about where can I go and get on? And that was the thing that struck me, interviewing people just days after they started the program, the number of people who said they weren't necessarily enamored of hydromorphone. That's a whole other story. That people's experience of it varied quite widely, from some people saying, yep, it's as good as gear, if not better, to others saying, this is the boringest drug I've ever had. But what was almost uniform was people saying, regardless of how they experienced hydromorphone at the time, they said, but you know what? 2 days has gone by and I haven't used heroin, and this is fucking miracle. You know, this is unheard of in my experience. But anyway, this is a particularly nice quote from a participant. It's short. My life has changed dramatically. My diet's changed. My sleep patterns have changed. My relationships with my family have changed. I've started to repair relationships with my loved ones. I've had to work out a new way to live. It's a dramatic quote. This was a very dramatic participant, but I love that. And the sentiment is not hard to grasp.
No. And I think it was, maybe go to the next slide, please, Liz. And this is the last for this section. I mean, at a glance, such a dull setting, right? but what I wanted to emphasize by including these pictures is that it's really the dignity of seeing people and recognizing, validating, putting weight behind, kind of underscoring the validity of the request and of the experience. So these two pictures, on the left is a bed at a particular clinic where if somebody wasn't able to get themselves, staff would help them. Staff would help inject them. And I thought, again, this is a really important recognition of what is most useful is that this treatment is maximally received by the person who's come today and asked for it. That is the best guarantee that we can give. And so receding behind anxieties around kind of other anxieties fails to service the objective of the treatment, ultimately can fail to service the objective. This other picture on the right-hand side is of the specialist leg injecting station. And I wanted to include it because it also underscores that not like huge resourcing is also not required. These are
so
simple
isn't it?
and approachable. I could put my leg up on that chair opposite and I could get my leg. You know, is as complex as it needs to be, because this is less about the technological and regulatory kind of advancement of an arbitrarily kind of extracted idea. This is about dignifying the needs and the identified needs and requests of the person in front of you and shaping those to what is going to work, what's going to land best for them.
Yeah.
I think, Anna and Jake, I'm just going to step in there just to move things along a bit, if that's okay. That's a wonderful presentation, and we've got a number of questions in the chat that I think we can come to as we round things up, because they relate very much to the Australian system. But we've specifically got a question on what the outcomes of programs of these programs look like, and obviously the concerns that are often stated here in Australia. Were they borne out in their results? And I suppose finally, how do those sort of outcomes align with what you've been seeing in the FOPIT study, Jake? So over to you.
I mean, in terms of FOPIT, the lovely Dr. Craig Rogers is going to release his, or the findings, I should say. Craig's going to be the first author on a paper looking at the sort of doing the numbers, basically. I think the point about FOPIT is because it was such a small trial, we're ultimately less concerned with numbers than we are with people's experience, both staff and participants, and how feasible that kind of model of care is. Because and we don't want to make this all about injectable treatment, as Anna said, injectable treatment is not necessarily, the prize. And it's not necessarily progressive either, I should say. Injectable treatment can also be delivered in a punitive fashion. But getting back to FOPIT, what was more important was if Australia is ever going to scale up an injectable treatment program, it's most likely going to be integrated within the existing opioid dependence treatment framework. And indeed, one of the kind of strong arguments for implementing injectable treatment in Australia is to use it as an opportunity to both reinvigorate and reorientate our existing opioid treatment program towards more person-centered care. So it was really, the trial was really less about the numbers and more about does this work? Is it acceptable? Is it feasible? My sense, certainly from participants, and I'm currently kind of writing up a paper at the moment looking at this idea of acceptability, which is fairly self-evident what acceptability is. And I would say in broad brushstrokes, there was lots of things about the trial that were really positive. It was far from perfect. There were reservations. There were particular points of criticism that participants had. For example, not everyone was enamored of the idea that, so FOPIT required that people, along with their 2 shots of injectable hydromorph a day, they also needed to be on a long-acting oral opioid. So if people weren't on opioid agonist treatment at the time they enrolled, they were put on methadone. Most people were almost by definition already on methadone, or in a couple of cases bupe. People weren't necessarily enamored of that. A couple of people had hoped that FOPIT might be, when they first heard of the trial, they hoped it might actually be a way that they could use injectable hydromorphone to reduce and then come off their methadone. Obviously, that person participated in the trial anyway. Interestingly, there were a few people who said, initially, I really didn't like the idea of having to be on methadone as well. But then certainly a couple of people acknowledged that that was possibly part of the combination. It wasn't just the injectable hydromorphone, it was also the methadone working in the background that kind of effectively allowed them to forget about their heroin use, because literally that was the term that people used, that they reached a point at which they just stopped thinking about heroin. There were, just going back to some of the kind of points of criticism, there was one of the study protocol included a requirement that people could only inject effectively from their wrist to their shoulder. There were a couple of people, one person in particular who was a long-term neck injector, who was incredibly reasonable about understanding that this was a trial and there were hoops that needed to be jumped through, etc. But at the same time, she ended up leaving early, and she was very candid that one of the reasons for leaving early, aside from other stuff that was happening unrelated in her life, that there was essentially a lack of reward for her, that because she was having to inject into her muscle, she found that both a painful experience, but also a kind of unrewarding experience. And which I guess just reinforces that idea that one of the appeals, obviously, it's self-evident, of injectable treatment is it's getting much closer to what people want. It's what people are already doing. And they don't have to give up the practice of injecting in order to go into treatment. And yes, we didn't offer diamorphine, pharmaceutical heroin, but we offered something that I think by and large was acceptable for people. Yeah, sorry, I could talk all day about this stuff, but
we might just use this. I think we've got some time allocated for the sort of practical lessons for Australia. So perhaps it's an opportunity to answer that through the second part of your presentation.
Sure. Thanks, Richard.
I was just going to say quickly before we move on, my initial thought was like, what outcomes to the question? Like, what exactly are we measuring here? And I think certainly from the Swiss, and and they're not uniform, but the Swiss clinics I had the opportunity to visit, social inclusion and quality of life were key. One clinic I was telling Jake about recently there was a football team that was both clinic staff and participants, and they played in the local leagues. Like the kind of like returning to the enjoyment of activities from which one had previously been excluded, by virtue of a number of barriers, was key. But the quality of life also written into the kind of prescribing mandates in Switzerland include, I started the sentence awkwardly. What I want to say is drug effect is part of the indication for prescribing. So how satisfied someone is with the medication is essential to consider, because satisfaction and retention is, again, why people keep coming back. There was another clinic, I mean, these guys are pushing like 90% retention on program, which is unthinkable. Yeah. But in fact, speaking to another clinician, again in Switzerland, they described that they had exhausted low threshold publicity. We've kind of like come and access treatment at our clinic. We've done all of these things and made the threshold non-existent. But it was in fact the cohort of professional classes who were dependent, who weren't accessing the treatment because they'd pitched it to this kind of low threshold cohort. So in fact, they managed to court new program participants by lifting the threshold and making a special door for these professional classes who were otherwise alienated from treatment, because they felt like, well, I'm not of this kind of social class, and so this isn't for me. But in fact, understanding the spectrum of need and pitching it in the manner that lands best with people is what is best going to enhance their quality of life. Again, sorry. So quality of life.
That's a very novel idea, tailoring treatment towards the people who use it. Why don't you continue on with the second part of your presentation?
Maybe, please. Thanks.
Can I just nip in, Anna, and just say that I mean, that whole thing about social isolation was just such a recurring theme amongst people who joined FOPIT. It would be really hard to overstate, I guess, the profound sense of kind of optimism and hope that people had in the trial, and accompanying that, their kind of sense of desperation that it's a well-worn trope, but the rock bottom thesis that these were people, and that's precisely why they were appropriate for FOPIT. These were people who had long experiences in and out of treatment, none of which had worked for them, and they were really so invested in FOPIT working. And along with that, I think, it's worth kind of reinforcing just what you said about the Swiss football team, soccer team, that alongside the importance that participants put on their relationships with staff was a knock-on effect that, as a result of their positive experiences of coming in every day and being greeted with a smile and really what should be the bare minimum of treatment, people's senses of self started to shift in a way that then translated to their experience of feeling kind of reintegrated in the community. Someone spoke beautifully about no longer, feeling like they could walk with their head held up, they could smile, and of course, people then smile in return. And so people's sense of identity and community came across really strongly, and community also with their fellow folk on FOPIT. That was also a really important touchstone, but how that then had a knock-on effect in terms of how people felt legitimated within the community at large, and I think that can't be overstated what an impact that would have when you look at the hostility with which the general public tends to treat people who inject drugs, and the hostility which gets extended to the treatments, particularly around methadone. So it was great to hear those stories, those observations from people over time.
Oh, absolutely. And I would also emphasize, as we've covered many times before, that can also be separated from injectable treatment.
Absolutely.
You know,
yeah.
like it's kind of, imagine the dignity of recognition, you know, and the kind of personalization of management, shock, you know. Yeah.
Can I, this is my last quote from Foppet, so I'm going to nip it in while I get a chance. This one, once again, this is about the therapeutic relationship. This quote comes from a staff member. And once again, this is not about saying that injectable treatment is inherently more person-centered than other forms of treatment. It's about a model of care. And what was required of participants, once again, partly because it's a trial, was that people had to have their vital statistics measured both before and after they'd injected, that being blood pressure, pulse, things like that. So there was a requirement that each and every time people came in, they kind of had to stay on the premises for a while. And I think, you know, people would be familiar with that term, the accidental therapist, but there was a lot of accidental therapy that took place not in a conscious way, but in a kind of often quite charming, relaxed, casual, everyday kind of way. That really, it was amazing how profoundly people came to value that. But anyway, this is the quote from the staff member. It's hard to have a therapeutic relationship in standard opioid dependence treatment. You might be honest about how much you're using and then risk losing your takeaway doses, things like that. Foppet gave people an opportunity to be honest about everything they were doing, and there was going to be no repercussions. It was just really nice to see, because so many people want an honest therapeutic relationship with their prescriber, but they know they can't. It was just great to see really open, honest relationships developing between clinician and participant.
It was an incredible privilege to be a part of that time.
So I think you wanted to talk a little bit more about a very different part of the world and a very different experience of injectable treatment, that being downtown east side in Vancouver.
Yeah, so I mean, naive me, definitely Act 1, Act 2, but I arrived in the way that I think is commonly accepted from where we stand in the world, thinking about the kind of like celebrating the successes in terms of harm reduction achievement in the community in Vancouver, with giving insufficient consideration to what they cost, the success of those, or the limited success of those, the literal body count I had underestimated, and it was with great humility that I realized I was turning up asking about a treatment that was no longer fit for purpose, essentially. And so I wanted to mention it from the point of view that the principles, woodworking and all, depending on the cohort, had actually been interrupted by kind of policy and regulatory processes, insofar as things hadn't moved sufficiently quickly, and need had far outstripped the kind of potential retention and effectiveness of these treatments had been outstripped by the potent and catastrophically dynamic contamination of the drug supply. And so it wasn't possible that these treatments could land in the way that they had so effectively retained so many people with personalisation in other parts of the world, in the European parts. And so I wanted to tell a story. This is an image of a different encounter, but I had so many, and this one is really beautifully symbolic. This person, in fact, I wasn't going to mention this, and I know we're probably running out of time because we talked long, but this was somebody who was actually a participant in Dolph's Compassion Club, who had then obviously ceased when that program had ceased.
Do you want to just quickly spell out DOLF for people who may not have heard of them?
DULF is the acronym, the Drug Users Liberation Front. And so Compassion Club, where people had purchased from the illicit supply drugs, medicine, to provide people who were members of the club with a safer supply, basically. So it was tested. Drug testing is widely available in Vancouver, well, less widely than it could be, but more widely than here.
And sorry, DOLF obviously operated completely outside of any approved regulated framework. It was a direct action initiative.
Absolutely. And I think there's a lot to read about it. So if you are interested, please go and read, because this is a wholly inadequate and understated description of their important activities. However, this person, after that was ended as a program, was also prescribed then, well, was subsequently prescribed under the Safer Supply program. They also sat with me with their illicit bought dilaudid tablets and described the number that were required in order to hold them effectively. And they're also using injectable where they could, but in an attempt to stay alive, they would try and limit the occasions that they were required to access the illicit market for street down, so to speak accurately. And the story that I wanted to best frame this with was actually with a prescriber who was describing to me, and we worked this out together on paper, where because of the privilege of the drug checking data meant that they could say that 1 point of street down, so opioids bought illicitly, would contain approximately 10 to 20% fentanyl. And so working this out in terms of morphine equivalency, it meant effectively that 1 point was equivalent to, like, say, with 20% fentanyl, was equivalent to 2,000 milligrams of morphine. And most people for whom this doctor was prescribing, or nurse practitioner, in fact, was prescribing, were routinely using 2 to 3 points daily, which made the upper ceiling of the prescribing regulations veritably homeopathic. And so the frustration and in fact, deep distress and moral injury that this person experienced in knowing that they could participate to a limit, but they didn't have the sponsorship of their profession or political sponsorship of regulators to meet the need that they were seeing, living in front of them on a regular basis, was very profound indeed, and humbling to sit with. I think, but I observed this distress in multiple settings, and I think it took me actually a very long time to appropriately digest it, because of how the depth and shame of these program failures. And yet, sorry, maybe go on to the next slide. I did meet so many people who were doing this incredible work, and in the spirit of the program options, continued. And when I say program options, attempting to deliver an equivalence of care, attempting to turn up best and meet the needs of those presenting needs of the people in front of them, fighting against the diagnostic overshadowing of, that often alienates people from treatment, effective or otherwise. I was going to mention, again, I'm conscious of time, but one of the pictures here, the two men who are in the kind of top middle, they worked at a rapid access program. And in fact, somebody unfortunately died in the car park outside while I was visiting them. And I mention it with great sadness, but to emphasize how present and acute this experience of frontline work is, and the unspeakable depth of loss that these people, and not just clinicians, community and clinicians amongst community, and lived with, and the degree of moral injury that they have sustained working in this space. But one of those men made the example to me that would we consider a program where somebody was prescribed a volume of alcohol to come and drink under clinical supervision on a daily basis, their best possible chance of success? And I think it's a no. I can't imagine that if doctors prescribe you must come and drink a litre of alcohol in front of me every day, or multiple times a day, that we wouldn't recognize how onerous that would be, but also how removed from the context of somebody's life that is, and how much that would deplete their agency in being able to take up the life that is ultimately theirs. And so to talk of overdose concern, and I'm mindful of the word overdose and how contested that is. So poisoning deaths, there's many variations, but to speak of concern in that manner and yet to not make available the very molecule or agent that would ameliorate against the procurement stress and ameliorate against that risk of immediate mortality is incongruous. And the frustration in what he described about those, the misalignment between policy and political conversations in public, regulatory pressures, and then what, as somebody who was there seeing community perish, and all the while knowing that like knowing that people were required, despite what was available to them under sanctioned models, would need to continue to access the illicit market was extremely challenging.
It just sounds like at least in downtown East Side, heroin habit is an anachronism really nowadays. That Indeed. Really it is about more likely to be a fentanyl habit or a nitazine habit. Just a small recommendation, a sidebar. Crackdown is the name of a podcast that's put out by Garth Mullins, who I'm pretty sure is the dude in the cowboy hat. It's absolutely fantastic. I mean, it's pitched as about harm reduction in Vancouver, but it's also in some ways a kind of profound potted social history of Vancouver over the last 2 or 3 decades. And I guess, Anna, it's, I think what we've been trying to emphasize is that, the molecule or the treatment drug itself can't be removed from the setting and everything that comes with it. But in some ways, your stories for Vancouver are also a reminder that they do matter. The molecules do matter.
They do.
And there we're seeing that, the available treatment medications are just not sufficient or sufficient in the numbers required to hold people in treatment. And it just sounds horrendous.
Well, absolutely. It's truly, I mean, instead of demanding people to survive on less and to have less relief, take up less space, have less options, shifting focus away from the pathology of substances to the pathology of harm is useful, and to understand what is most harmful in people's lives. I mean, heroin-assisted treatment or injectable treatment of any form is onerous, and it's no longer of use for many of the people I met in Canada. They struggle to retain people on program in the conventional form of it that we might look to. And in fact, a lot of the people that we know from FOPIT, and we've discussed this many times, it's chosen not necessarily because of what it is, but because of what it isn't. And it isn't replicating typically, although it is onerous, it isn't always replicating some of those more punitive or restrictive practices that we find in conventional oral treatment availability.
And Jake, I'm just in the interest of time, I'm just going to ask you to see if we can wrap things up very quickly, because we've just got to leave a little bit of time for questions.
Yeah, no worries.
There's so much to say. This is really just about kind of understanding that high support and high risk, actually meeting people's needs at a lower, well, and not lower threshold in the conventional meaning, but we can lower risk by meeting people's needs well, essentially, and that the intensity of care doesn't mean the same thing always. This requires more explanation, but maybe crack on, and I'll just skip ahead.
You've got about a minute.
Oh my goodness. Okay, clinical. I'm going to skip ahead again. Sorry. This is about the order of how we prioritize kind of what our clinical versus regulatory and professional obligations are in building this. I think current programming, maybe skip ahead again. Sorry, Liz. This was a comment on relational pieces. I'm going to summarize. I'm sorry.
Yeah.
I think at the moment we're asking people who we recognize have the least power and carry the greatest burden of vulnerability often, and that's not everybody, but people who do, to carry the most risk in this programming. And I think that it's entirely warranted that in building something, that we build it from need, and that we put people, and we also shoulder some of that, people with integrity who are involved in building this, clinical, operational, professional processes, that we understand what's required, not bolted on to the side, rather step forward, because expecting people to, we're expecting things from people without resourcing them well, and without listening to what people are asking for in order to do well, is essentially a cruelty. And I think this is an incredibly important opportunity to upscale, to build something smarter and more equitable. I think this is the basics of what we do. And from a clinical point of view, medication administration point of view, at its very fundamentals, right person, right drug, right dose, right route of administration, and right time. These are 5 rights that we are schooled in our training. And I think that they have not been effectively applied here. This is enormous. And I think this is a huge opportunity to build consensus about something that can make a material difference for the future, because it is, it's not enough, and it's no more trials, it's no more pilots. Let's build a prototype. Let's make it now, and not in the spirit of kind of incrementalism versus absolute overthrow. We can build this today by making the practical changes that Annie has acknowledged that we know about. These are real material possibilities that can start. So that's
Thank you. Thank you very much. Look, just again, because we've got to make sure we finish on time, I'm sorry to wrap it up early, but
someone had to shut us up, Richard.
Yeah,
thank you.
That's right.
I
shouldn't say earlier. Look, from my perspective, in politics, we often talk about the Overton window, which is this sort of idea that there's this range of acceptable ideas and mainstream ideas, and really the policy solutions you're looking at have to exist within this sort of what's called the Overton window, which is this sort of constrained area of public policy. And for me, the power of something like your presentation is to just show us that there is another way to do this. And there's a much better way to do this, and it's meeting people where they are and providing options. And so for me, that's what I found, particularly with the European examples, and just some of the photos which demonstrate a very different model to provide people with those options that are going to meet their needs, and not the needs of regulators or policymakers who are constrained by their own biases and sometimes prehistoric training. So I think for me that's where I see power in that, and all the comments in the chat generally are urging Australian policymakers to really move ahead with this. We do have, again, just because as I said, we want to get people off at 3 o'clock. There are a couple of small questions that I think Greg Denham's asked about what's actually happened to the participants in the FOPA trial.
Yeah, that was from Greg, was it?
Yeah.
Just before I answer Greg's question, I think just to reinforce...
You're going to have to be brief, though.
Yeah. I just think we need to be so mindful that stigma in this field not only shapes how we understand what is acceptable and quality healthcare, but how we imagine it. And I can't overstate
Absolutely.
that.
Absolutely.
We don't necessarily know what's happened to FOPIT participants because, as a researcher, we didn't have ethics approval. I interviewed people up to 3 months. In fact, it was mandated that I interview people 3 months and a day after their final shot of hydromorphone. I did that, but we don't have the authority to chase people up or the ethics to do that.
Okay, great. Thank you.
Totally. Yeah.
I'm also going to bring Annie in here because there's been there are a few questions around training, and particularly the National Centre for Education and Training, trying to get a sort of view around national standards for prescriber training and registration. And I think the same sort of question was asked around pharmacists. There's always this tension, isn't there, between achieving standards and putting people off.
Yes.
And I think Jared was keen to know his organisation delivers training for pharmacists, but they're resisting the calls to make it compulsory. Is there a review about what we need to do in terms of compelling people to engage in it, and obviously the risk of keeping people away?
Yeah, look, this is really tricky, and I've worked with some others on this in this webinar over the years on training programs and webinar-based work, online, in person, for GPs, for prescribers, not with pharmacists so much, I need to say, but and I'm a real supporter of those programs. But we've always struggled to get people to come along to those. I think part of it is that, GPs and pharmacists, but particularly GPs and nurse practitioners, they're really busy people, and finding time for people to go to training. But you know what I'd probably say? Training is important, but just based on what we've been talking about today, I wonder whether we need to prioritise more just having conversations, and going to Jake's point about how important it is to imagine what else might be possible, what might be different from how we're currently doing things. Because training, I think, very often is a go-to for reinforcing what is, and saying these are the standards, these are the guidelines, these are the regulations, whatever, and you become so entrenched in that your capacity to imagine a different way of doing things becomes less. So I know it's not really answering the question, but I would say, formal training, yes, and CETA and places like that are absolutely our go-to people for that sort of training, and the RACGP and organisations like the colleges. But I do think maybe we need to make more space for actual conversations about how we create a modern, ethical, flexible, attractive program for people.
And I think that really goes to, again, Alison's point here, which is if we don't get short-acting injectable treatment, how do we reflect those principles of dignity and respect and freedom that we've seen in those European examples within the current treatment system? Because if we can't do it already with what we're doing now, we've got no hope of offering that in an expanded program. So I think the work that HRA is doing, personally, I know we've got a trial set in Victoria. I agree completely with you, Anna. Let's stop doing feasibility studies. Let's stop doing trials, and let's start implementing what we know works. And we know that injectable opioid treatment works for some people. And as I think you've been at pains to say, this is not about preferencing one form of treatment over another. It's about giving people options and ensuring that we're meeting people where they are. We're tailoring our response to the people sitting in front of us, not to some theoretical patient. So that is, I think, really at the heart of it. We do, as I said, we are very much almost at time. So we're going to wrap things up. I'm going to hand it over just to Annie to say a few words, and then we'll say goodbye to everybody. But over to you, Annie.
Yeah, great. Liz, if we could just bring up those last two slides. So while Liz is doing that, I'll just reiterate to everyone, as I've said before, we really want to hear from you. Next slide, please, Liz. Really want to hear from you. If you do have comments you want to make over the next couple of weeks, please, you can reach out to any of those organisations listed there, or others you might know are involved in this process heading towards into Canberra. But at least those ones there are sponsoring today and the other webinars. So please feel free to reach out to any of us. And next slide, please, Liz. I'll just quickly sort of say the other two webinars that are coming. So next one is on Tuesday, the 25th. Please come along. That's on pharmacotherapy systems, mapping challenges and best practice. So really leads nicely on from today, looking at what we've learned and what it means for opioid treatment. So some really great new research there that will be revealed. And then importantly, on the 2nd of September, just before the forum, consumer consensus on the optimal delivery of the opioid dependence treatment program. This is all about hearing from AVIL and its membership and consumers from a living experience perspective on what people on treatment really want. Back to Richard there. You can hit that link to find out all about these two webinars. Over to you, Richard.
Thanks, Annie. So there's a couple more. Make sure you register and join, and we hope to be able to take your voices to Canberra in a few weeks' time. Again, I just want to thank everybody for joining us. I did a lot of work in Parliament across a range of sort of areas, and it really does strike me that this is one of we've done a lot to combat stigma and discrimination across areas of race and gender, but it just staggers me that we still have one of the most stigmatised and marginalised group of people in our community, and our responses are lagging well behind. So I want to thank Harm Reduction Australia as the organiser for ensuring that we bring together, this wonderful group of people. I want to thank ABSAD and the AADC, and of course all the AOD state and territory peaks who have helped fund the webinar and the Canberra Forum. Click on and join those second and third webinars. And with that, I just want to thank you all for joining us in a really productive and hopefully useful conversation. So thank you very much.